talk about today we're going to talk about the outcomes of the mechanical thrombectomy for the interfacility transfer versus the direct hub hospital admissions. That's part of the studies we did about 2 years ago with Dr. El-Nazi. She was then a resident at that time. I don't have any financial disclosures for this project. So acute ischemic stroke is the leading cause of the long-term disability, and this is the fifth cause of the mortality in the United States. It's a very disabling disease. And acute stroke, ischemic stroke with large vessel occlusion, that's the most severe form of the ischemic stroke, which account for about 20 to 30% total ischemic stroke patients. But it's the major cause for post-stroke morbidity and mortalities. It accounts for 60% for overall disability and mortality. So this is the most severe form of the acute ischemic stroke. Unfortunately, the medical treatment only works about 10 to 20% large vessel occlusion stroke patients. So we need additional treatment interventions to open the vessels to improve the outcomes of this form of the stroke. The road to get mechanical thrombectomy as a standard care for the large vessel occlusion has been a long, bumpy journey. The mechanical thrombectomy or local intra-arterial thrombolysis has been used for many years. That leads to the first randomized clinical trials. It's called the ProActive 2 trials. The trial was completed in 1999. This is the first clinical trial shows the positive benefits for the intra-arterial thrombolysis improved outcomes. This trial was divided two groups. Or one group is the patient was treated with the standard medical treatment with intra-arterial infusion of the pro-urokinase into the MCA occlusions. On the control group, those patients are going to be on the IV heparin drip. The results showed 40% of the IA treatment patients had more favorable outcome compared to 25% in the control groups. Because of this treatment, so the stroke guideline at that time recommended for the IA thrombolysis within 6 hours in the selective candidates. Dr. Ramo at that time was the PI for these trials at the University of Louisville Hospital. When the trial was performed, then the IVTPA trial was also underway. So on the control group, all the patients didn't get the IVTPA. Since then, there's first generation of the mechanical thrombectomy device was invented. The first one was called the Massey retrieval. This is the helical coils mimicking wine corkscrews. This was first invented at the UCLA in 2005. Later on, they formed a company called Mercy Concentric Companies and designed that this is named as a Mercy Retrievers. On the right side, the pictures on the top ones, you can see that this device, the Mercy device, basically this device usually use the wires penetrate the clots and advance through the clots, then deploy the device, then use the device slowly pull back to engage the clots and take the clots out. They did a single arm studies. They found that 49% of the patients who had recanalized the arteries had a more favorable outcomes compared to 10% on the patients who didn't get the artery opened. The first device was approved by the FDA for the mechanical thrombectomy on the large vessel occlusion stroke patients. Several years later, another company called the Penumbra Company, they designed another device called the direct contact aspiration device. This device, the first generation device, has different size. This is showing on your right lower part, and this device has the clot separators and paired with the microcatheters, and those microcatheters by the end connect to the pump that's showing on the lower end. The idea is the separators and to disturbing the clots. At the same time, the aspiration applied to the tip of the microcatheters. That's how the clots get the separate and aspirate to the aspiration pump. That's to recanalize the arteries. This was also done the single arm clinical trials, and that's called the pivotal trial. This trial showed that 29% of the patients on the recanalized the patient has a more favorable outcome compared to 9% when the patient still remain occluded arteries. Both trials actually shows about 70 to 80% recanalization rate, but the favorable outcome is only about 40% and 29%. After those two trials, and the question is really if we do run a randomized clinical studies, whether those devices can show the benefits. So this is there's several clinical trials who were performed at that time. The most famous one we call the IM3 Interventional Management of the Stroke. This is phase 3 trials that was completed in 2013. This trials including about 600 patients, and in a 2-to-1 ratios. Two of them, 400 patients, was assigned to the mechanical thrombectomy patients with the IVTPA, and 200 patients that was assigned to the control group only with the IVTPA, because all those candidates was within the 3 hours. The trial was published in New England journals. There's no any safety concerns, but there's no significant benefits was noted. There's at the same time, there's two more clinical trials was completed. One is called the synthesis expansion, which mostly was done in Europe. This trial was a 1-to-1 ratios. There's 180 patients getting mechanical thrombectomy with IVTPA, and the other half was just get IVTPA within 4.5 hours. This trial was prematurely stopped and didn't show any benefits either. The other trial was completed take a much longer time to completions, and it was premature discontinued because the IM3 trial results. This trial only got about 120 patients in the enrollment because take a much longer time, almost 3 years, and they look at the 120 patients within 8 hours of the onset, then use the compared to the mechanical thrombectomy versus just standard care. All those 3 trials draw the same conclusion. There's no benefits for the mechanical thrombectomy. This is slightly different from the general perceptions for the mechanical thrombectomy benefits on the large vessel occlusions. There's some reasons for the failure of those trials. Number one, there's no any vascular imaging requirement to screen to confirm the large vessel occlusions. Some of the patient was all the patient, especially on the IM3 trials, the patient enrollment depends on the patient whether have a large vessel occlusion signs. They enroll the patient. Then some of the patient was included in the control group. Then it goes in. There's no any large vessel occlusions. At that time, the CT angiogram or MRA to confirm that large vessel occlusion was not required. And also the first generation of the mechanical thrombectomy device are not effective as was initially thought, and the enrollment would take much longer time to get enough candidates for the trials. Because of those lessons we learned from those 3 clinical trials, in 2015, there's 6 more new trials was complete. The first one was then called MR-CLIN, multi-center randomized clinical trials of endovascular treatment for acute ischemic stroke. This is the trial was done in Netherlands. This is the first randomized trial demonstrated benefits of mechanical thrombectomy on large vessel occlusions. They enrolled about 500 patients. They divided in 1-to-1 ratios. Within all the patients was within 6 hours of the stroke onset. The CT angiogram or the MRA or cerebral diagnostic angiogram was required to verify the occlusion of the large vessels before the enrollment and the randomizations. And this trial showed the positive benefits of the mechanical thrombectomy on the elbow patients. At the same time, there's 5 more trials was still ongoing. Then all of them are stopped prematurely because the positive results from the MR claims because they don't feel it's ethical to continue enroll the patient and assign it to the control group. We are decided for the 3 primes and the other studies called extended RA, escaped stress, and the REVASC. All those studies on the final analysis showed the benefits of the mechanical thrombectomy. And these trials even use more advanced image like a CT perfusion or CTA collateral scores to find more suitable candidates for the mechanical thrombectomy. Because of all 6 clinical trial positive results, the American Heart Association stroke guideline was updated, and the mechanical thrombectomy became a standard care if the patient had a stroke within 6 hours. That was in 2015. In 2018, there's two more trials which more use the advanced imaging and looking at the extended windows for the mechanical thrombectomy, because we know more people presented to the hospitals usually beyond the 6 hours. So there's two trials using the CT perfusion studies, and they try to find out the candidate maybe still still the good candidate for the mechanical thrombectomy. The first one is called the Dawn trials. It's a very long name of these trials. I never remember those things, DWI or CTP assessment for clinical mismatch in the triage or wake-up stroke and going neural interventions with trivial device. This is what the clinical trial was sponsored by the Stryker company. They enrolled about 200 patients, 1-to-1 ratios, 107 patients undergo to the mechanical thrombectomy, and the 99 patients go to the standard care. Those patients usually are beyond the 6 hours, but within 24 hours. At the same time, there's another trial called the Diffuse 3 trials. They look at the patients between 6 hours to 16 hours. As 92 patients had the mechanical thrombectomy, and then 90 patients only received the standardized medical treatment. And both trials showed the positive results within 24 hours of the stroke onset. And all those trials are focused on the anterior circulation, same as the MR Clean and the other 6 trials. Those all just are focused on the large vessel occlusions in the anterior circulation, either RCA terminus or proximal M1 occlusion, or proximal A1 occlusions. These two trials not only extended windows for the mechanical thrombectomy, also shifted the decision making from the time windows to the tissue windows, which use the CT perfusion studies. Because of these two positive clinical trials, and the stroke guideline was updated in 2018, so mechanical thrombectomy is recommended in the extended windows with more selective criteria. Since then, since 2015, there's more patients undergoes to the mechanical thrombectomy because mechanical thrombectomy is the standard care for the large vessel occlusions. This is just the diagram that shows currently mode in the most of the places in the United States. How do we get the patients for the mechanical thrombectomy? That's two level of the hospitals the patient usually go. Either they go to the nearest primary stroke center or nearest emergency room. We call the spoke hospitals. At that place, the patient may get a CT scan, and there's a telephone call or maybe telestroke seen by the vascular neurology over the phone of the videos to give the IV TPA. And then if they decide the patient may have a large vessel occlusions, the patient going to leave the hospitals and transfer to the hub hospital, usually is a comprehensive stroke center or mechanical thrombectomy ready hospitals for the mechanical thrombectomy. So we really on the comprehensive stroke centers, you have a two type of the stroke population for the elbows. One is inter-facility transfer patient. The other one is directly admitted to the comprehensive stroke center patients. This is a study by Satish Shah that was published in last year. They are looking at the database from GET with the guideline stroke from 2012 to 2017, and they are looking at the interfacility transfer numbers for mechanical thrombectomy. As you can see, after announcement of all those 6 randomized clinical trial positive results, the transfer patient for the L mechanical thrombectomy has significantly increased. And at the same time, Jeff Savers, after the 6 randomized clinical trials, within 6 hours, he summarized all 6 clinical trials, and he found the benefits of the mechanical thrombectomy decrease from the time the symptom onset to the mechanical thrombectomy. The longer time you wait, the benefits you're getting less. On the left side, you can see. On the left side, you can see about at the 420 minutes, the benefits of the mechanical thrombectomy close to 0. On the right side are the pictures. You can see that the percentage of patients for the modified ranking scales over the time, the medical treatment on the bottom lines and the mechanical thrombectomy on the top, they merge together. So the question right here is whether those patients, obviously the patient take it from the transfer mode for the mechanical thrombectomy have a much longer time from the time of the onset to the artery recanalizations. The question was whether the transfer patient had the same benefits for the mechanical thrombectomy compared to the patient directly admitted to the hub hospitals. This research did by Dr. El-Nazi and working with Dr. Ozan, and Dr. Remo and myself. We are looking at our strict database for all the mechanical thrombectomies between 2015 and 2017. Basically, all the mechanical thrombectomy patients we did at the university hospitals. We divide the eligible patient into 2 groups, the transfer group and the Mothership group. And we reviewed all the patients' basic demographic informations, neurological deficit pre-procedures, and the procedure variables. And we look at the outcomes from the how much the percentage of the arteries were recanalized and the patient's outcome on the discharge. The clinical outcome was measured by looking at the age and NIH stress scales on the admissions and on the discharge and the modified ranking scales and the complication rate. If the patient had the ticket TIC, a ticket score 2B or 3, were considered a good recanalizations. A favorable outcome is considered when the modified ranking scale on the discharge was between 0 to 2, and the good outcome with modified ranking scale between 0 to 3. It's the results out of the 116 patients. We have about 40% was transferred from outside the hospital, while 60% was from the direct admissions. There are more female patients in the direct admissions compared to the male patients. In the transfer group, there's more male patients compared to the female patients. The mean age and NIH stress scale on admissions before the procedures both were about similar. The median NIH stress scale was 17. The time to the last normal to the growing puncture side in the transfer group is about the median time is 397 minutes, and if for the direct admissions on the Mothership side is 267 minutes. But we didn't find it on the significance between the two groups in the p-values. That's probably because we are including all the patients. Some of the Mothership patients, they are beyond the 6 hours and get it into the 24 hours, and that's probably make the statistics has no any significance. By looking at the outcome, the recanalizing rates for the arterials, they're pretty much same, 80% and 72% at direct admissions. The NIH stress scale, excuse me, NIH stress scale on the discharge about is about the same, but the percentage of the favorable outcome, the direct admissions almost twice as much as transfer groups. If we look at the good outcomes, including the modified ranking scale 3, they're almost about double the percentage. We didn't get on the good outcomes. We get a significance and the p-value is 0.03, and the favorable outcome was we're close to the significance, but we didn't get the less than 0.05. Probably due to the small number of the patients. Then we further look at the patients that the stroke onset within 8 hours. The transfer patient has a 102 minutes longer median time compared to the direct admissions. And the transfer patient has much less favorable outcomes, 22% versus 34%. The Mothership had a 60% patient had the TPA compared to the 48% patient got the IV TPA. The p-value of the favorable outcome is about 0.1. I think probably it's the much less patient numbers make the no statistic significance. So this retrospective studies does showed the patient with the interfacility transfer has less benefits despite the recanalizing rate as good as direct admissions. The limitation for these studies, this is a retrospective small sample studies, and we don't have all the patients with 3 months by ranking scales because some of the patients are lost of the lost the follow-up in the clinic. we cannot get the time between the last normal to arrive the outside the hospital and from the outside the hospital take how long to the university hospitals, and all for the we have a variety of the referring hospitals for the procedures. Some hospitals are very close by, just like a Jewish downtown hospitals. Some of the hospitals as also can go to TJ Simpson. That's several hours away. So I think the heterogenic geographic distance is also can be, make the conclusions a little bit obscured. In 2017, there was one study looking at the one device. This study was open-labeled registration studies, and this study was sponsored by one of the device company. This study was done by Michael Fowler at the Vandenberg. So basically, this from these studies is called strategic registration studies. And for these studies, they look at the patients, 984 patients within 8 hours, and they can separate the patient from direct admission to the hub hospital and transfer from the outside hospitals. They have about a similar percentage, about 45% patients was transferred for the mechanical thrombectomy. There was a significant delay from the time of the onset to recanalization on the transfer patients. It's about 100 minutes difference between transfer patient group and the direct admission group. They do show a significant difference of the time of the delay. Overall, there's more on the direct admissions. There are more favorable outcomes. You can see more patients have a modified ranking scale 0 to 2 versus the transfer group. And they further look at the two other. They further look at the subgroups. One group is the mechanical thrombectomy only, and on this group they have similar findings. The direct admission patient doing better than the transfer patient. The other group is the patient who get IV TPA during the before the mechanical thrombectomy, and in this group, actually, the transfer group and the direct admission group has no significant difference in the benefits. When they look at the excuse me, when they look at the predictors for the outcomes, they found patient's age and the initial NIH stroke scale and the time lapse between the onset and the mechanical thrombectomy all contribute to the outcomes. If we have the patient getting older, the benefits getting less, more severe stroke, and the outcome getting worse, and the longer time from the time of the onset to mechanical thrombectomy, the less chance of with favorable outcomes. This study is similar to us, but they are within the 8 hours. That's why the results is more clear. In last year, there was a systemic review and the meta-analysis studies looking at the direct admissions versus the transfers by looking at all the studies was published in the online in the PubMed, Embase, and the Cochrane database, and they looking at the these two groups for the outcomes, and the 17 studies was analyzed. The 9 studies had a small percentage with the posterior circulation occlusions. And from the results, this showed that direct admissions had a high chance of having favorable outcomes at 3 months among the 5,258 patients. And they looking at the recanalization rate, complication, and the mortality in the hospitalizations in the 3 months. On those outcomes, there's no any significant difference between the direct admissions versus the interfacility transfers. And what they found is on the from the time of the onset to the green puncture and from the onset to the recanalization OTP and the OTR, there was a significantly longer time in the transfer patients. about 92 minutes and 83 minutes. They also look at the subgroups with the patients with got IV TPA. There's no significant difference between the direct admissions versus transfer group. So this is quite similar to the strategic studies. And so the question is, we still didn't know whether when the patient for the interfacility transfers, whether the IV TPA may be bridging, used as a bridging method, maybe can compensate for the negative effect from the prolonged the time for the recanalizations. Similarly, this study is also the retrospective studies with pull the all the other studies. They also had a heterogenic distance between the referring hospitals to the hub hospitals. Maybe there's a different inclusion criteria for the baseline demographics in the different studies. The studies for the IV, including the IV TPA, only has the small numbers, only 5 out of 16 studies. So from all those retrospective studies, we know we get a sense that if the patient had the use interfacility transfer mode to get the mechanical thrombectomy, probably has less chance of getting favorable outcomes. There's a study by Jeff Saver at the UCLA, and he used the same strategic registry database to analyze these 984 patients. And for those patients, they made it to hypothetical bypass scenarios. One is when the patient come to the stroke, they may not go to the, they may directly go to the mechanical thrombectomy hospitals. That's the one they by the in the trials from, if let's say if the patient was in the primary stroke center A and they finally go to the stroke hospital B, and after stop at the hospital A, and then one hypothesis, they maybe take the patient directly from the onset location to the hospital B, bypass the hospital A. The other thing is from the other hypothesis is when the patient is in the locations, they just go to nearest mechanical thrombectomy hospital. That's just the hypothetic hospitals. Probably patient didn't go that way for a variety of reasons. And they look at the 236 patients with the known stroke scene, so they can pinpoint the location of the patient where it is when he had a stroke. Then there's 117 patients transferred by the ground. And there's, in that group, 62 patients transferred within 20 miles radius, and 114 patients were transferred by the airborne airlifting. So they look at those 236 patients, and the first column is the first column is the location of the stroke onset to the initial hospital. That's about 6 miles, and from this hospital, initial hospital to the endovascular mechanical thrombectomy hospital is about 30 miles. And from the first hypothesis, if they bypass the the first hospital to directly go to the mechanical thrombectomy hospital, that's about 34 miles. And if they go to nearest hypothetic mechanical thrombectomy hospital, that's about 28 miles. So if they so the onset to the endovascular hospital, it takes about, in the actual world scenario, that takes about 217 minutes. But if you bypass the initial hospital, just directly go to the final endovascular hospitals, it only takes about 106 minutes. If we go to nearest hospital for the mechanical thrombectomy, it only takes 96.5 minutes. You probably got this. But in that scenarios, when the patient needs to give it IV TPA, that takes a little bit longer time. It's about 14 to 25 minutes longer time if we directly go to the mechanical thrombectomy hospitals. But overall, because you save much larger time from the onset to the mechanical thrombectomy hospitals, you probably compensate for the delay, slightly delay in the IV TPA part. And they're also looking at if the patient, the location within 20 miles distance between the intervals, and you can see even much significant improved the time, the onset directly to the endovascular door. If we get in the real situations, in the registrations, it took about 208 minutes. But if we bypass the primary stroke centers, directly go to the mechanical thrombectomy centers, and it takes about 61 minutes. If we just go to nearest hospital in the hypothetic mechanical thrombectomy hospitals, even take less, about 56 minutes. So from these studies, really told us that if the patient may be better, if the patient within the 20 miles distance, maybe it's better to bypass the primary stroke centers and directly go to the mechanical thrombectomy hospitals, save much bigger time, and probably the patient have higher chance of getting favorable outcomes. We all know all the transfer patients, we call the elbow alerts all the time in our hospitals, but not all the transfer patients did get the mechanical thrombectomy. And the next question is, we're looking at how much percentage of the patients who was transfer intended for the mechanical thrombectomy, and how much finally got the mechanical thrombectomy. Having several studies since 2011. The first one is on the calling it Figure B. That's a single center retrospective studies from 2006 to 2010 at the Rush University in Chicago. They have looked at the patient with elbow within 12 hours. At that time, there was 132 patients was transferred for the mechanical thrombectomy. That's only about 40% patient finally to get the mechanical thrombectomy. The other two studies is more recent, Figure A and the Figure C. Figure A was the both are also single center studies. Figure A was the single study in Ghana regions. I probably think that's from either in France. That's the European studies that looking at the 2012 to 2017 and that time frame, and the patient with elbow within 4.5 hours. 278 patients was transferred for intended mechanical thrombectomy. Only 125 patients, but the 125 patients didn't get the mechanical thrombectomy, so only 55% patients got the mechanical thrombectomy. And similar findings in MGH. There's about they had the lowest percentage of patients who got mechanical thrombectomy, about 27%. So a lot of patients, because the longer term delay for the transfers, a lot of patients who didn't get the mechanical thrombectomy. There are several causes for the patient who transferred for we call the futile transfers, or eventually didn't get the mechanical thrombectomy. That's the open observational registration at the Madrid, Spain, from 2012 to 2013. The most common reasons for the patient transfer and they didn't get the mechanical thrombectomy actually is they have a clinical much improvement, or maybe have arterial recanalizations. The second most common criteria is the patient is the neural images shows the patient is no longer is a favorable candidate for the mechanical thrombectomy, and that's another 8%. The patient already has much more significant clinical deteriorations for that. The study by Rishi Gupta published in 2016, he looked at the aspect scores of his single centers. At that time, he looked at all 42 patients who was into hospital transfer. At that time, all those patients had the normal CTs as with the aspect score above 6. All those patients, and then after the transfer, all those patients had the repeated CT scan. It's about 1/3 of the patient, the aspect score from the favorable for the mechanical thrombectomy become unfavorable, and aspect score less than 6. So definitely there's dynamic changes and progression of the stroke during the transfers. So it's almost 1/3 of patients are no longer become a good candidate for the mechanical thrombectomy. The other studies was published in JAMA 2017. So they're looking at the factors maybe contribute to the infarct progressions during the interfacility transfers. This is retrospective studies for a single hub. They have even large 30 referring hospitals from 2010 to 2016 at MGH. They found if the patient is female, or the patient and has a more significant NIH stress scales at the outside the hospitals. If the patient had the CTA shows the more proximal occlusions, and more importantly, if the patient collateral the blood vessels scores are much worse, then the patient the aspect has more likely had the decrease the favorable scores on those patients. This study really tells us that with the time lapse, the stroke is going to progressions. Most likely on the patient, if it has already had a severe stroke, or patient had a poor collaterals on those patients, with further delays, the patient may not have good outcomes. It's just a diagram shows the CTA collaterals for the studies. What they found is they did multivariable studies when they can find the referring hospital NIH stroke scales, the initial aspect scores. If it gets worse, then usually patient get more infarct progressions during the transfers. On the table 3, they are looking at the variables that's obtained from the endovascular treatment hospitals, where they found, in addition to the initial NIH stroke scale and the initial aspect scores, and also the collateral blood flows on the CT angiogram, and also contribute to the worsening of the stroke. So pretty much from this conclusion is the mechanical thrombectomy is beneficial for the large vessel occlusion acute ischemic stroke patients, but with the interfacility transfers, the benefit may not as good as those with the direct admissions. That's because some patient has not had the good collaterals, or maybe already had the severe strokes. The time windows for them to get the mechanical thrombectomy are much shorter than the other patients with the good collaterals. So the current transfer mode will let those patients miss the opportunities of getting favorable outcomes just because they don't have inadequate collaterals. And the 30 to 50% of transfers are futiles, and with the this is also increased the burdens on the emergency room at the Mothership hospitals or hub hospitals, because the numbers we can see, the numbers of the transfers are increasing every year, and they try to allow the more patients get the benefits for the mechanical thrombectomy. At the same time, this also put a lot of burdens for the emergency department in the Mothership hospitals. There's a formal trials called the Risk Actor trials in the Europe. Probably finished the enrollment in last year. They're looking at whether how the interfacility transfers compared to the direct admissions, which way is better than the other. There's also a lot of studies. They try to use alternatives to current transfer mode, such as the one proposed by Jeff Saver, is bypass the primary stroke centers and just go to the endovascular capable centers if within a short distance, such as within 20 miles. That makes sense. Maybe instead of transfer the patient to the endovascular hospitals, maybe just send endovascular team to that hospital to perform the mechanical thrombectomy there, so they can save the time for the transfer patient to here, because that's taken much longer time to transfer the patient. Use the ambulance to another hospital while you can just send the staff down there and perform the mechanical thrombectomy. But that's also required that the referring hospital has the capability to have the equipment for the mechanical thrombectomy, as well as has the care afterwards. The other choice that was recommended by some vascular neurologists, that's all the new vascular neurologists can be trained with the required IR scales just for the mechanical thrombectomy. So when they get into these primary stroke centers, and they maybe can do some mechanical thrombectomy there, when they finish, the mechanical thrombectomy, they either can keep the patient stay in that hospitals or maybe transfer to the comprehensive stroke center for the much better care. So those people are just explore those alternatives for that. The other things maybe we can expansion the utilization of advanced neuroimaging studies at the referring hospitals such as CT perfusions, something like that, and the CTA and the CTPs. So we know some patients maybe a candidate for the transfers for the mechanical thrombectomy, maybe keep the patient just keep in the hospital if there's no endovascular treatment need to be done, so that can minimize the futile transfer and decrease the burden of the emergency room. I think that's all for today.
Thank you, Dr. Liu. You ran through many years of experience, and it has been a rocky road. I think that we will be discussing a lot of these important topics that you brought up about transfer and the delays at next month's International Stroke Conference. How much of an impact in your experience would the TPA, being able to give the TPA at the outside hospital? I know that you talked about several studies, but in your experience with our center, if they got TPA and then transferred for mechanical thrombectomy, is that going to make that difference? Because you had we in our study had 48% compared to, I think, 60% that got TPA first. Can you talk about that and what impact it would have?
We look at the TPA group, but we didn't find any significant benefits because I think our number of the cases are much smaller. So that's probably why when we ran the statistics, and we didn't see the significant the difference between these two groups. And practically, we do see some of the patients get IV TPA. When they get into our ER, their symptoms are much improved. Some of them, I had 3 cases, they got it here, they got the TPA, then when we take it to one, we got the CT angiogram, all the vessel was opened. The other 2, we get into the lab, then we do the angiogram, then the clots was already dissipated, become more distally. We don't have to do any mechanical thrombectomy, and those patients are doing very well afterwards. I think, if the patient, if the patient, like in the Taylor Regional or TJ Simpson, they're several hours away, maybe the IV TPA benefit. The patient very near the downtown, maybe can pass the Jewish downtown hospital directly to the UofL, maybe make more sense. I think the distance between the transport hospital, referring hospital to the endovascular hospitals, I think it also is a consideration for that.
Thank you.
Lilu, that was an excellent and provocative presentation. I had a couple of questions. One is that, in terms of trying to prevent these futile transfers, are these patients, more likely to have a smaller or no perfusion mismatch, and is that predictive of which patients may not need transfer? That's the first question. The second is that there seems to be a difference. If you look at the MGH group that actually underwent mechanical thrombectomy versus the French group, it looked like in Boston, 1 in 4 patients that were transferred underwent thrombectomy, whereas in the French group, 2 in 4 patients underwent thrombectomy. So why this difference? And also that is there a chance that if the patient gets too early to a place and is done, you go for endovascular treatment too soon? Are you over-treating some patients? And is there a way to know which patients are being overtreated?
That's a good question. First question is, I think yes. If we get if we can expansion the CT perfusion or CTAs in the outside the hospitals, and if they did the CT perfusion that shows there's no significant mismatch, so the patient usually not a candidate for the endovascular treatment, and those patients does not have to be rushed transferred to the emergency room at the endovascular hospitals. That's for sure, and they can either decide to keep the patient or they still can transfer patient, but those patients can bypass the emergency room and directly admit to the comprehensive stroke centers for more complicated care for that. Because some patients, if they have a large vessel occlusions, they may have cerebral edema, they may need craniotomy or those things. The referring hospital may not be able to handle those things, so they still need a transfer, but they don't need to go to the emergency room, try to activate the staff for the possible mechanical thrombectomy. That burden can be decreased. I didn't know what's the underlying difference between the MGH group versus the French group. Apparently, the French group had more patients get the mechanical thrombectomy versus the MGH group. I think the MGH group is similar to us because when the patient got into the endovascular hospitals, they usually have to do the advanced image like a CT perfusion and the CT scan to make sure the patient is still the candidate before they take to for the mechanical thrombectomy. While on the French group, they probably just based on the CT angiogram from our referring hospitals, they just take the patient directly to the angio suite for the treatment, and that may, I didn't look at details about how much the difference between the outcomes on those between these two groups. So probably the French group maybe have more cases for the mechanical thrombectomy, but the outcome may not be as good as the MGH group.
That was a fantastic presentation, Velu. That was really impressive. Thank you very much. And thank you for the tremendous work that you have done and everything that you have impacted in this community and this region single-handedly. That's really quite impressive. So thanks very much.
Thank you, Dr. Perry.